Alex Shorter. A few ground rules. Please keep yourself muted during the presentation and feel free to make a note in the chat or unmute yourself if you'd like to ask a question. We're delighted to introduce our speaker for today, Professor Rick Neptune. Professor Neptune is the John T. McGuire Professor and Chair of Mechanical Engineering at the University of Texas at Austin, where he directs their Neuromuscular Biomechanics Lab. His work focuses on biomechanics and rehabilitation of healthy and pathological gait, and he's made many important contributions, including seminal work understanding how muscle coordination and mechanics relate to human walking and balance function. He's also studied, developed, and analyzed innovative orthoses and wheelchair systems. Professor Neptune earned his PhD from UC Davis and has received numerous awards, including the NSF Career Award, the Vance Mao Medal from ASME, and he's a fellow of the American Society of Biomechanics. On a personal note, I had the pleasure of interacting with Rick when I hired one of his MS students recently, Hannah Frame, who's a staff engineer and manager in my research group, and she's been doing an excellent job. So thanks to Rick for that. So without further ado, please welcome Professor Rick Neptune.
Okay, can you see my slides, Elliot? Is that good?
We can, yeah, we can see it.
Okay, great. Well, it is an incredible pleasure and honor for me to be here today to share some of my past and current research. And the University of Michigan has a long history in biomechanics, and especially human movement and neuromotor control that I've admired and followed for all these years. And there's a number of people here that I've known for quite a while. I don't think Brian Umberger is here, but Dr. Umberger, I remember when he was a young whippersnapper at ASU, he was a student there. And now he's there with you all. And Deanna, of course, was a student here at UT Austin, and have known a number of you for many years. I'm Ashton Miller. We've served on NIH review panels together, and have known him for quite a while. And so, again, I'm honored to be here and share a little bit about the type of research that we do that is really aimed at improving rehabilitation outcomes for those that have movement disabilities. And historically, we focus on individuals that have post-stroke hemiparesis, lower limb amputees, and then those that have spinal cord injuries that can constrain them to wheelchairs. And so what I want to do is highlight a bit of what we do in our lab. And this is a busy slide, but I just want to provide a general overview of the type of studies that we do. And I'm going to try and hit on a few of the different studies that we've done over the years and what we're currently doing. Our group combines experimental studies where we analyze human movement in the lab. A big part of what we do is use additive manufacturing to make prototypes of prosthetics and orthotic devices. UT Austin has a long history in additive manufacturing. Selective laser sintering technology was invented at UT Austin in the Department of Mechanical Engineering. And so we've used that technology to make prototypes, put them on human subjects, and to test them. And I'll highlight a couple of things that we've done over the years. And then we also do quite a bit of work using modeling and simulation techniques to be able to gain insight into causal relationships between the impairments an individual has and their task performance. And so we've done work in wheelchair propulsion, modular control, design optimization, and so forth. And so I'm going to try and highlight just some of those things that we've done recently. And so in terms of additive manufacturing, some of our earlier work that we did was really focused on trying to improve the comfort and performance of prosthetics sockets, and amputees often develop high pressure contact areas that can lead to ulcers and so forth. And so we did a bunch of work trying to develop a framework to be able to take a scan of a residual limb, generate a point cloud, and ultimately a CAD model, identify those high contact areas, and then build a prototype and actually to test them on human subjects. And so one of the challenges that we found to have this technology adopted in the clinic is really just the framework to take a scan of a residual limb and ultimately end with a functional prototype. And there was a lot of steps involved and a lot of data processing and so forth. A lot of that has been streamlined, but that's one of the challenges that remains to get this type of technology into the hands of prosthetists, to be able to use on a regular basis. If you think about additive manufacturing or 3D printing, I mean, that's really ideally suited for subject specific devices. And so hopefully with time this technology will continue to develop. We've also done work with prosthetic foot ankle devices. This is one of the first projects that we did. It was a lot of fun. It started off as a senior design project. They were trying to develop a low cost prosthetic ankle for third world countries. And so we developed a prototype, and here's a subject using it. And what was really fun about this project is after he was done with it, he did not want to give it back. And so we knew that we were successful when he didn't want to give it back. And so having this design allowed us to do a lot of systematic studies in terms of varying the stiffness properties and seeing how it affects gait performance. And so this led to other studies where we looked at the whole foot ankle device. And so this subject was always fantastic to study and analyze, because we put a wide range of foot stiffnesses on him, ranging from like walking in a ski boot all the way to a very compliant one that was like flip flops. And it didn't matter what we put on the end of his prostheses. He would walk back and forth a couple times and he would say, "I'm good to go." And if he was wearing a pair of pants, you could not tell that he was a lower limb amputee. And so from my perspective, I was really interested in what were the adaptations that he was going through to help his walking performance. And I don't know how many of you know who Ann Silverman is, but that's her back here. I'm giving the thumbs up that the subject actually hit the force plates. And so if anybody has ever done an experimental study, overground gait study, you know how exciting it is when they actually hit all the force plates, when they're going. So anyways, we've done some systematic studies of looking at the influence of energy storage and return on gait performance. And one interesting study that we did is most studies have been done on lower limb amputees and straight line walking, and we wanted to assess the effect of coronal plane stiffness on gait performance. And so we had this individual here who was walking around, and again, one of the challenges was to set up the force plate so that would be able to get good force plates hits there. And it's kind of fun now. My son is a mechanical engineering student in our department, and he's keep carrying on this work looking at coronal plane stiffness, because one thing that we found is that I'm depending on if the residual limb is on the inside of a turn versus an outside of the turn. There's different stiffness requirements, and so Kendrick, my son, is extending that work, and it's been a lot of fun to have him in the lab working on the project. We've also looked at ankle foot orthoses, and specifically we looked at strut stiffness and axis of rotation. And so Nicole Harper and Ellen Rands did a series of studies where we took our additive manufacturing techniques and made struts and systematically varied the stiffness characteristics. But also an interesting point is we varied the bending axis. And so we were able to do that through the geometry. If you have a uniform strut, the bending axis is essentially in the middle. And in this case, through geometry, we were able to have a low, mid, and high bending axis. And our hypothesis was that they would prefer a bending axis that was lower to the anatomical ankle joint. That actually ended up being not the case, that they actually, it varied quite a bit from subject to subject, depending on what their injury was. And so some actually had ankle injuries, other had compound fractures and so forth, and so it varied quite a bit across the subjects. But we were able to use additive manufacturing to make quickly make different prototypes. And so now I'm going to switch gears a little bit and talk about a work in understanding muscle function and coordination. Again, big picture wise, our group is trying to improve rehabilitation outcomes for those that have movement disabilities. And in order to do that, we really need to understand what is the effect of individual muscle impairment and how individual muscles work together in synergy to perform a given task. And so we combine experimental studies. Here's an individual that has post-stroke hemiparesis, and we can generate corresponding simulations and start looking at what are the individual muscle contributions to things like step length and balance control and body propulsion and so forth. And so for those of you that aren't familiar with what a four-dynamic simulation is, it's really analogous to how our neuromusculoskeletal system functions. I mean, there's a neural control input. All of our models really start basically control starts at the waist down. We don't have models of how the central nervous system is interacting with the spinal cord and so forth, but we have a neural control input that acts to stimulate the muscles that are governed by activation and contraction dynamics, intrinsic muscle properties, force length, force velocity, relationships play an important role in determining the magnitude of the muscle force. So you have a neural control input, stimulates the muscles that's governed by highly nonlinear properties that produces a muscle force that's applied to all of the body segments. And if you think of muscles, they really just behave like force actuators that are applied to all of these link segments. An important aspect of that, though, is to have an accurate musculoskeletal model in terms of lines of actions and moment arms, and how you model the kinematic joints, because ultimately that determines the torques. And so we solve the corresponding equations of motion. Really, this is just a glorified Newton's second law, F is equal to ma. We'll use numerical techniques to solve for the accelerations, and numerically integrate those to get the corresponding velocity and position. And so four dynamic simulations provide a really powerful framework to identify the causal relationships between the neural control inputs and the resulting to task performance. And then once you have a predictive simulation, you can go in and do some really nice studies on the influence of specific muscle-tendon parameters, or even musculoskeletal parameters, on how that affects the corresponding motion. And so it's a very powerful technique to analyze, human movement. But a very challenging aspect of that is to come up with the neural control inputs that produce a well-coordinated movement. And part of that is the lack of fidelity that we have in terms of measuring, individual muscle EMGs, and also the finite set of muscle excitations that we can actually measure. And so we've spent quite a bit of time developing an optimization framework that allows us to quickly converge on all of these muscle coordination patterns, that produce a well-coordinated movement. And so once you have a forward dynamic simulation of a movement, you can go in and start understanding what is the functional roles of individual muscles. And so if you stimulate a muscle, it generates force and power. You can actually quantify through segment power analyses and other techniques on where is all of that energy going, and what is the functional role that particular muscle is performing. And so we've done a number of studies over the years analyzing muscle function and coordination. And one of the most important ones that we did was one of our earliest ones, and that is to look at the functional roles of the ankle plantar flexors. And it turns out that both the uniarticular soleus and the biarticular gastrocnemius really have different functional roles in terms of which ones provide body support, forward propulsion, and accelerating the leg into swing. And so throughout this talk, I'm going to provide a bunch of references. I'm not going to go into great detail on specific studies, but if you're interested, in these areas or topics, or a particular study, you're welcome to go and have a look at these studies in more detail. But we've looked at differences in muscle function during walking and running at the same speed. We've done quite a bit of work with modular control, or others call those muscle synergies. We've looked at muscle and prostheses contributions to amputee walking mechanics. You looked at joint contact forces. I mean, that's a really powerful aspect of forward dynamic simulations, to be able to estimate joint contact forces, and because you can't measure those directly. And we've also looked at muscle contributions to balance control during amputee and non-amputee walking. And so Nicole did a nice study analyzing stair ascent. More recently, we are interested in the influence of load carriage on knee joint loading and metabolic costs for lower limb amputees. And predictably, individual amputees rely on their intact limb as a compensatory strategy to meet the increased demands of carrying a load. But what we learned and didn't know before was that carrying a back load was found to increase intact knee joint loading relative to carrying a front load. But the back load actually reduced the metabolic costs. And so there was a trade-off in terms of intact knee joint loading and metabolic costs in how you carried a load, whether you carry the load in the front versus the back. And so I'm expanding these analyses to look at different loads on the side of the body and so forth. And so what our modeling and simulation framework allowed us to do was to actually go in and look at what muscles were responsible for the increased metabolic costs and joint loading. And so, for example, your hamstrings here, you see that its metabolic power was much higher during the front load, and that had to do with its functional role of the hamstrings in controlling balance control in terms of acting to rotate the body backwards. And so when the load was in the front, it required, increased, hamstring activity to to rotate the body backwards. And so we were able to interrogate the model and simulation to understand all of these relationships. And so I'm currently expanding this work. And so Ty Templin was a student in the lab. For those of you football fans, it was actually fun. Ty was a scholarship wide receiver for the Longhorns, and it was great having him in the lab working on this project. Another really powerful application of modeling and simulation is design optimization. And so we are interested in improving passive prosthetic devices. And so Nick Fye was a graduate student in the lab, and he did a series of studies really trying to understand the influence of prosthetic foot stiffness on muscle function during amputee walking. And he also performed a design optimization, coming up with the optimal stiffness characteristics of the foot, and how those stiffness characteristics should vary throughout the keel and ankle to minimize metabolic costs and impact knee joint loading. And so again, modeling simulation is a powerful framework to be able to do this, because you have the dynamic interactions of the musculoskeletal system, as well as the design that you are trying to optimize. And to be able to do this effectively, you really do need to have these dynamic interactions between the device of interest and the corresponding musculoskeletal system. And so it's a really powerful technique to be able to do this. And we're all another application is trying to improve sports performance. So my wife and I are competitive cyclists, and we often do long endurance rides. This is me, and this is actually my wife back here. I don't know if you can see her helmet, but we've done a number of double centuries and 12-hour time trials. And so as an engineer, there's been many times I've been out in the middle of a 12-hour race and trying to think about how I could possibly get more power output during our time out there. And so I had an excellent student, Jeff Rankin, who was interested in a design optimization to improve sports performance. And so we optimized a chainring shape to maximize power output during pedaling. And this was actually a really fun study. We ended up coming up with this elliptical shape chainring, and we published this in 2008. And kind of a point of trivia, I don't know if you know who won the Tour de France in 2008, but it was Carlos Sastre, and he was actually the first Tour de France winner to win using a non-circular chainring. And it turns out that the shape of the chainring that he used was almost identical to this shape that we had come up with. So that was really fun to see, and a nice validation of our work that our optimization found. And Jeff went on to actually look at the influence of seat position on crank power and so forth. So this was an actual fun application of modeling simulation to try and improve sports performance. So now I'm going to switch gears a little bit and to talk about the work that we're doing with spinal cord injured individuals who are constrained to wheelchairs. There's about 3 million wheelchair users in the United States, and unfortunately, up to 70% of those will develop overuse injuries over the course of their lifetime. And muscles play a critical role in propelling the manual wheelchair. And so we're trying to understand what are the relationships between, muscle demand about the shoulder joint and the propensity for them to develop overuse injuries. And so the cycling work that Jeff did was a part of his master's. He has stayed on to do a PhD, and he was the first one in my lab to use modeling simulation to understand wheelchair propulsion. And so as a part of his PhD, he did a series of studies looking at the influence of altering push force effectiveness on upper extremity demand. He quantified individual muscle contributions to both the push and recovery phases, and also the influence of propulsion technique on upper extremity demand. And so this was a nice series of studies that really gave us insight into the relationships between propulsion technique and upper extremity demand that may lead to overuse injuries. And so we followed that work up with I'm John Slowick. He was looking at optimizing seat position to minimize metabolic cost, and also upper extremity demand, which we quantified with muscle stress. And so we systematically varied the fore-aft and up-down position of the wheelchair user, generated corresponding simulations. And basically, this was a sensitivity analysis that we did. And it turns out that the optimal seat position that minimized metabolic costs and muscle stress was almost identical for each one of these parameters. And that very rarely happens, that you'll look at different parameters and there's a sweet spot where something is minimized. And what was nice is that this provided some nice prescription guidelines in terms of wheelchair setup, because we were able to plot this as a function of the hub shoulder angle and also the elbow angle. And it's just so this is important for clinicians when they're initially prescribing a wheelchair to a given subject, to be able to set that up in such a way that it'll help minimize metabolic costs and muscle stress. And so John went on to look at the influence of speed and grade on wheelchair propulsion hand pattern. And it turns out that wheelchair users generally use one of four patterns. Okay, so either they use a simple arc pattern where the hand just glides back and forth on the top of the hand rim. They use a single loop pattern where they push and then loop back over the top and grab again and push, loop back over the top. But what's interesting is many wheelchair users actually use a double loop pattern where they actually push. They start to come back up on a single limb, then they drop their hand back down and come back and grab the hand rim again. And so you get this nice double loop pattern there. And then there's a semicircular pattern where they push and then just drop their hand down, come back up and grab the hand rim. And so what we were really interested in is understanding the relationships between propulsion technique and upper extremity demand. And John did a really nice series of studies where he used modeling and simulation to gain insight into that. And then Shelby was an undergraduate student in the lab, and then she has stayed on as a graduate student, and she extended this work looking at relationships between propulsion technique and the propensity to develop pain. And I've been fortunate to collaborate with Sarah Mulroy down at the Rancho Amigo Rehab Center in California. They had an incredible database of 230 wheelchair users, where they had brought them in at baseline 18 months and 36 months. And at baseline, none of them had pain. And we're able to track the development of pain over time. And so we were able to look at relationships between the propulsion technique that they use, and it actually changed over time, and whether they develop pain or not. And so we did some experimental studies and modeling and simulation to gain insight into that. And Shelby is just now finishing up her PhD work, where she's generating simulations of those different time points to gain insight into all of these relationships. So now I'm going to switch gears again and talk about our work with dynamic balance. I mean, it's a fundamental task in human movement, but it's also very challenging for a number of different patient populations, such as older adults, individual post-stroke, lower limb amputees. Everybody appreciates falls can lead to injuries, reduced physical activity, but ultimately that cascades down to an overall reduced quality of life. And so what we want to be able to do is assess dynamic balance using quantitative methods to be able to design rehabilitation interventions to detect and treat balance disorders. And so currently there's a number of clinical measures that people use. These are discrete score assignments while they perform tasks. And so there's a Berg balance scale, the dynamic gait index, functional gait assessment, and so forth. And the advantage of these is, especially in a clinic, is that these are simple, global assessment to be able to assess the risk of falling. But the problem is many of these show floor and ceiling effects, and also they provide little insight into the mechanics of the observed changes in balance or the potential deficits that an individual has. And so there's other more detailed laboratory-based balance measures that people use. And one of the popular ones is margin of stability, which you look at the minimum distance between the base of support and the extrapolated center of mass, based upon the work of Hoff. And the problem is margin of stability is really looking at the motion of the center of mass with respect to the base of support. And again, it's a global general measure. We have gravitated towards analyzing balance and balance control using whole body angular momentum. And we like it because it's a mechanics-based measure. It counts for the mass, movement of all the body segments with respect to the center of mass, the inertia of all of the segments, and so forth. And so you can either determine it based strictly on kinematic measures. Also, we have looked at the time rate of change of whole body angular momentum, which is equal to the external moment about the body center of mass, which is equal to the basically the moment arms of the feet and where they are generating ground reaction forces with respect to this center of mass. And what we like about this is those moment arms are really a function of the foot placement with respect to the center of mass, and so both step width and also step length, and the corresponding ground reaction forces. And you can look at the external moment generated from the left leg and the right leg, and that is really nice when you're analyzing pathological populations such as lower limb amputees and individuals post-stroke that have asymmetries between limbs. And so we can gain insight into the mechanics of the time rate of change of angular momentum, or how they are regulating their balance control. So some important first steps that we did is we wanted to compare all of these clinical measures with whole body angular momentum to see how are they related. You looked at correlations between these various measures in both healthy controls and individuals post-stroke, and what we found was that the measures are correlated, that those that had a higher range of whole body angular momentum, and when we say range, that's the peak to peak value, how much it varies across the step cycle. So we found a higher range of whole body angular momentum is associated with a higher margin of stability, wider step width, and then these lower clinical balance scores, BBS and DGI, which are indicative of those that have poor balance control. And we saw that there's some really nice, significant relationships between those. And so Arian Vistamer was a PhD student in my lab, and still continuing to work with her now. And then also Steve Counts at the Medical University of South Carolina. We've been longtime collaborators. In fact, Steve and I were grad students together in the same lab. And so we have a 30-year collaboration together, which has been wonderful and has allowed us to look at a wide range of studies of human movement. And so once we determined that there was a correlation between these clinical measures of balance control and whole body angular momentum, we were able to start analyzing various populations. And one of the first things that we did was looked at differences in angular momentum between below knee amputees and non-amputees across walking speeds. And so here's some of that data here. Here's non-amputees have very symmetrical patterns. Amputees are very asymmetric. And so we were able to analyze the external moment and see these differences here. This higher peak to peak was really due to the fact that the lower limb amputees had lower propulsion. And so in order to compensate for the lower propulsion from their residual limb, they had to decrease the corresponding braking so that the net whole body angular momentum over the gait cycle was 0. And so that I'm explaining the observed asymmetries that they had, but it also explained why they're also much more susceptible to falling, because they had a higher peak to peak angular momentum. And so we've done a number of studies. Ann Silverman was a student in my lab, and she's now at the Colorado School of Mines. And we did a number of studies looking at amputees, but also incline, decline walking, stair ascent and descent, and even compared the balance control between passive and powered lower limb prostheses. And again, angular momentum was our measure that we use to assess the balance control. And more recently, we've been looking at trying to stabilize balance control. And Hannah Frame, I think she's in the audience, so I'll go ahead and let her explain her study. No, I'm just kidding. I'm kidding. So this was Hannah's study. She was a master's student in our group, and did a fantastic job on analyzing the influence of lateral stabilization on walking performance and balance control. And we compared both healthy and individuals post-stroke. And the whole idea behind this study is we were thinking that stroke patients that had impaired muscle coordination to control their balance, they may have been needing to use a number of compensatory strategies that may interfere with their walking performance, such as providing full forward propulsion and so forth. And so our thinking is that if we were able to stabilize the body and actually control their medial lateral balance and actually eliminate the need for them to provide that balance control, that it would actually, eliminate those compensatory strategies and actually may improve their walking performance. And so that's what our goal was. And so we applied medial lateral stabilization. It stabilized their pelvis, but we did not see any changes in their gait performance. Their asymmetries did not improve. And contrary to our expectations, both groups, both the healthy controls and also the individuals post-stroke, actually increased the range of their whole body angular momentum. And so we stabilized the pelvis, but their whole body angular momentum actually increased. And so the advantage of analyzing whole body angular momentum is that we were able to go in and look at individual body segments and how they were moving with respect to the center of mass. And it turned out that the culprit for the increase was an increase in the relative velocity between the pelvis and the hat segment, between the head, arms, and trunk. So we actually stabilized the pelvis, but the upper body, because of that stabilization, actually moved more with respect to the pelvis. And so it actually did the exact opposite of what we were thinking that it would do. And so that actually has important implications for locomotor training. You often see therapists that are stabilizing the pelvis when people are walking. And so maybe we need to give that, some more thought. And so following all of those studies where we just analyze, balance control, we were also interested in what are the individual muscle contributions to controlling whole body angular momentum, which are the primary muscles that are controlling a balance. And so Craig McGowan was a postdoc in my lab, and he and I did some modeling and simulation analyses that allowed us to analyze individual muscle contributions to whole body angular momentum. And we looked at muscle contributions to sagittal plane and also frontal plane balance control. And the take home message is in terms of controlling balance, the hip adductors, the gluteus medius, and the ankle plantar flexors, both the soleus and gastrocnemius, are really critical to maintaining and restoring dynamic balance during walking. And so this has important implications for rehabilitation interventions to target these muscles that may be helpful in improving balance control. And along those lines, we recently did a modeling simulation study that looked at muscle contributions to medial lateral and anterior foot placement during walking. So when we think about balance control and placing your foot, you often think that during the swing phase, or the swing phase muscles are the ones that are critical for foot placement. And one of the, to me, one of the interesting outcomes of this study was that many of the contralateral limb, the stance limb muscles, play an important role in placing the swing leg of foot during walking, and it has to do with their contributions to moving the pelvis. And so your stance leg muscles can move the pelvis, which ultimately moves the foot. And so both the stance leg muscles and the swing leg muscles really play a critical role in foot placement during walking. And that was something that I didn't have a full appreciation of before going into the study. I was just thinking, primarily what controls foot placement is the swing leg muscles, and it turns out that both stance and swing leg muscles are important to accomplish that. So in terms of balance control, we've looked at people during steady state tasks, but we've also used perturbation studies to try and understand balance control, but then also using perturbation studies to understand our response mechanisms, which has important implications for designing prosthetic components. And so I've had a long collaboration with Dr. Glenn Clutie, who's up at the Seattle VA Medical Center. And ultimately, what we were interested in is coming up with a design for a coronally clutching ankle to improve balance control when you step on a coronally uneven and unpredictable terrain. And so Dr. Clutie has expertise in designing really cool, powered prosthetic components. And so we were working with him to just try and understand the balance and recovery mechanisms when you step on unpredictable terrain, and looking at the adaptations and so forth. Courtney Shell was a PhD student in my lab, and she worked on identifying classifiers to be able to predict when somebody steps on an uneven terrain, to be able to use as input to the prostheses controller. And so here was a unique testing paradigm that Glenn had. We had a hidden surface here, and people would step on it, and he would either invert or evert. And again, we were analyzing how do they respond to that unpredictable terrain. So this was a fun series of studies, but we also used whole body angular momentum to be able to quantify balance control and how they adapted to that perturbation. More recently, we've been looking at step width perturbations and how that influences balance control. And Glenn had developed this a unique pneumatic device that basically provided a burst of air to perturb the foot just before heel strike. And Lydia Brew is a PhD student in my lab, and we expanded the device to have a two-way valve, and so we can perturb the foot either medially or laterally. You have a tank of compressed air, some solenoid valves. We have an IMU and microprocessor to be able to predict when they're about to hit the ground at heel strike. And so about 100 milliseconds before heel strike, we would perturb the foot either medially or laterally. The individual didn't know when that was going to occur. And we looked at their balance control and how did they adapt to that. And it turns out that when you perturb the foot laterally in this blue curve here, that it really has no effect. But if you perturb the foot medially, and we're talking both the medial and lateral perturbations were on the order on average of about 3.6 centimeters, that when you perturb them medially, it actually had a huge effect on their balance control, and they became unstable. And so we were interested in the mechanisms that they used to recover, and it was a combination of an ankle strategy and a hip strategy as well. So this pink region here is the duration of the perturbation, and so here's the perturbed heel strike. And when it occurred, and these were healthy controls, and you can see they recovered pretty quickly during the corresponding perturbed stance phase. And so what was fun is at the same time, we also combined these steady state walking and these perturbations with a dual task condition. And so what we did was we had the people walk and stand with no cognitive load. We had them walk while they we had headphones on, and we're playing them a story. And we told them that we were going to test them at the end on information about the story. So we wanted them to be paying attention to it. And then we also had them spell short and long words backwards. And so you had an increasing cognitive load from passive listening to spelling short and long words backwards. And we wanted to see what was the influence of cognitive load on balance control during walking. And so Ella Small is a master's student in the lab, and what we found was that in young healthy adults, that balance control decreased during the dual task walking. So the walking along, and they're having to spell words backwards. They have a cognitive load, and their balance control decreased. But the cognitive performance, spelling percent error and response rate, did not change versus, standing and performing those cognitive loads versus walking and performing those. And so the decrease in balance control suggests that the participants prioritize their cognitive performance over their balance control. In other words, as they're walking along, their priority was to spell the words correctly, rather than them being concerned about their balance control, which systematically got worse as the cognitive load increased. Okay, so this was the first step in our dual task study. Is we just had them walking, and we gave them a dual task, a cognitive load, and we looked at their balance control. They perform well on their cognitive task, but their balance control decreased. Then what we did was, while they were walking and they had the cognitive load, then we perturbed them, and to see if the cognitive load had any effect on the balance recovery strategies that they used. Okay, and so cognitive performance decreased between the unperturbed and perturbed conditions. Okay, and while the balance control decreased, okay, during the perturbed condition, the additional cognitive load had little effect on balance control during the perturbations. In other words, it stayed the same. And what was interesting was the balance recovery strategy was unaffected by the addition of a cognitive load. So our rationale is that because of the cognitive load, there would be a delay in their response to the perturbation. And so our thinking was that they would use an ankle strategy, which is actually much quicker to change the center of pressure. You would help restore their balance control, compared to a hip strategy, which would take a bit longer to do. But it turns out that their strategy that they used did not change. And so here's an example down here of their peak hip abduction moment. Here's the percent gait cycle down here. So this is where in the gait cycle the peak occurred. Here is their steady state unperturbed walking. And then these are all of the medial perturbation conditions of no load listening, short and long word spelling tasks. And then here's the lateral perturbation. And so it's essentially, there was no difference in the strategy that they use. And so this suggests that individuals prioritize balance control over the cognitive task when faced with an impending perturbation. The downside to this study is we had to let them know that a perturbation was coming, just the way that we had our protocol set up. So they knew that during the trial that they were going to get a perturbation, and so that drew their cognitive resources towards maintaining their balance, and their corresponding cognitive performance actually ended up going down. And so anyways, this was a really neat and fun two-part study. It's a new area for me in terms of dual tasks. And so starting to combine, cognitive aspects of walking with, the automatic nature of walking, and mixing those two together has been a really interesting set of studies that we have done. So that is kind of an overview of the type of work that we do in terms of, understanding the biomechanics and neuromotor control of human movement. I've been able to highlight some of the experimental studies that we've done, how we've used additive manufacturing to change the design characteristics of prosthetics and orthotics, and use modeling and simulation to analyze various aspects of human movement. And so I've presented a number of studies that we've done over the years, and I've been extremely blessed with excellent students that have participated in all of these studies. And of course, there's one that has always stood out, over the years, and that's Hannah. And you guys are fortunate now to have her up there at the University of Michigan. And I was thankful for the time I had with her in the lab, and glad that she's there with you all now. So anyhow, I am more than happy to open it up to any questions y'all might have.
Thanks, Rick. Thanks for the very nice talk. Yeah, please. So feel free to go ahead and unmute yourselves and ask questions, or go ahead and ask away in the chat, and we can get started if anybody's got something on the tip of their tongue.
Maybe I can start. I have a question. So something I've been wondering is, would you say the role of angular momentum is here in gait? There's some studies by Marko Popovic and Hugh Herr talk about regulation of angular momentum. And I'm sort of wondering, do you think this is something that's controlled by the nervous system or by the body, or do you think it's a downstream resultant factor of something else that maybe is more important?
Yeah, so that's a good question. I think what we control in human movement is certainly a multifactorial. So I use whole body angular momentum to try and generate a simulation of human movement. So basically walk from point A to point B and minimize angular momentum, and it gives you a walking pattern that is not normal walking mechanics. And so you think about all the things that are important. And so joint loading, balance control, muscle stress, metabolic costs. I mean, there's so many things that could potentially play a role. A classic example is pedaling, right? So many think that energy expenditure plays an important role in the actual pedaling rate that you select, and it makes intuitive sense. But if all of us were to hop on a ergometer right now and pedal at some fixed power output, say 200 watts, all of us would gravitate towards 90 RPM. And so, a logical guess is, that's where our energy expenditure is minimized. Well, that's not even close. It's minimized at about 60 RPM. And so, I mean, it's really not, it's not like it's 80 versus 90 RPM. I mean, it's not even close. If you want to minimize energy expenditure at 200 watts, dial down your pedaling rate to 60 RPM. And so what is it that our nervous system, is optimizing? And what's really interesting and intriguing is that, that's the same for non-cyclists and competitive cyclists. And so there's something really intriguing going on there. And so I tried experimenting with a bunch of different cost functions, right? So pedal at 200 watts and minimize muscle stress, or some other cost function. And the closest I've actually come, which is really interesting, is I had the optimization minimize joint loading. And it turned out that in terms of pedaling mechanics, that was actually the closest that any other cost function that I had played around with came to actually predicting normal pedaling mechanics in terms of pedal reaction forces and things like that. And so I think there's a combination of things. I do think balance control is important. We can have a long conversation about the role of step width. I mean, to me, an intriguing question is, why do older adults, individuals post-stroke and so forth, who are susceptible to falling, why do they walk with wider step widths? Because in static standing, just in standing, it makes in perfect intuitive sense. If you have a wider base of support, you're more stable. But when you're walking in a dynamic situation, as soon as you pick your foot up, gravity is rotating your body the other way. If you analyze, these older adults and individual post-strokes and lower limb amputees who are more susceptible to falling, they walk with a wider step width, and their peak-to-peak range of whole body angular momentum is higher. And they are the ones that are most likely to fall. And I think what it might be related to is it's not so much while they're walking that they have a wider range, but I think it could be that if they get perturbed while their angular momentum is out near that peak, which is higher, and if they don't have the capacity to be able to help recover and restore from that perturbation, then there's a good chance that they're going to fall. And I think there's something related to that. And but there is this perception that wider is better. And from a purely mechanics point of view, you lift the foot up, you've got this huge moment arm now that you have to be able to control. And I'm not so sure that that's the case. But then it brings up the intriguing question, well, then why do they do it? I mean, they're doing it for some reason. So that's what's interesting.
Thank you.
All right, so there's a question in the chat here from Edgar. Thank you for this practical perspective to biomechanics. Do you think that non-passive actuation of coronal plane motion for lower limb prostheses could have a significant impact in balance?
So a non-passive, that is, so non-passive control, so powered control?
A non-passive, yeah, we can have jump in.
Completely actuated, yeah.
Okay. Yeah, so yeah, I think there's a huge role for powered non-passive devices. I think one of the biggest challenges that exists is to understand user intent, to be able to communicate that. And I know Elliot and others have done a lot of work in this area, trying to predict terrains. You can come up with a control algorithm to walk in some steady state pattern, but all of a sudden you could come up to the top of a set of stairs, and you have to stop and then change your control algorithm. I mean, how do you communicate that to your prosthetic device? And so human movement is so dynamic, and it's constantly changing, and so that'll be a challenge. I'd come up with a non-passive control algorithm to be able to predict when it should be actuated and when it shouldn't, and so forth. But yeah, I of course I think there's a role, but I also think it's going to be a challenge for the control algorithm as well.
Thank you.
How about Michael Bai? Does he have a question or is he hiding out?
Oh, I'm just lurking here, Rick. I'm intrigued by your cycling stuff. I think if I was in that photo with you and your wife, I'd be about a mile behind you guys. That was my recollection from 20 or 30 years ago.
Michael and I were students together, took classes together at Davis, so I'm pretty neat.
Go Aggies. I actually had a question about the optimal seat positioning.
Yeah.
So you talked about how there was this relationship where you, if you looked at metabolic cost and stress, you tended to see those tended to minimize together. And I'm trying to wrap my head around this, so bear with me. But if muscle stress is just muscle force divided by cross-sectional area, and if metabolic cost is essentially, at least the way I'm thinking about this, so feel free to correct me on it. I always think about metabolic cost as kind of like a weighted summation of like muscle activation, essentially. We can argue about whether or not that's dead on or not, but shouldn't those vary relatively together? I guess I'm confused. I guess
Yeah.
like
Yeah, no,
it's
they're
more complicated than that, right?
Yeah, it's a little more complicated than that because the a metabolic cost takes into account active heat and fiber types and all of these other things. But you're right; they will be. There will be some correlation there because muscle stress is a function of the forces, but we were looking at peak stress, and so we were picking a value there, and so but yeah, they'll there is some correlation, but they aren't exactly the same.
Sweet, thanks. Just trying to wrap my head around it.
Yeah, good. Good question.
All right, so it looks like another one in the chat from Gray. Gray, do you just want to go ahead and ask your question?
Sure. Great talk, Rick. How well do musculoskeletal models today predict the mechanical impedance of the lower limbs?
I don't think they do.
They don't?
That well. I don't think so. One thing that is interesting is our metabolic cost models and also our muscle excitation values. Seem to be much higher than they ought to be for just simple steady state self-selected walking. And I think a big part of that is that our models don't have sufficient joint stiffness, and it's not clear where that joint stiffness comes from. So I think we need to have excess co-contraction, to be able to produce a well coordinated movement. And so when you look at our estimates of metabolic costs, they follow trends correctly. Like if you were to add loads and other things, I mean, it scales the same way, but there always seems to be this offset. And if Brian Umberger was here, he could talk about that as well, because I know he's spent quite a bit of time thinking about his metabolic cost model. And also our excitations often for muscles like the vasti for steady state walking, the excitations are maxed out. And you're wondering why in the world, is it maxing out? And you can scale up the muscle forces, but they are pretty close to being what they ought to be. And so I've always thought that, yes, we are missing something at the joint level in terms of impedance and stiffness, at our joints. And I don't know if that's the passive structures that are doing that, and viscoelastic properties in terms of fluid and other things that are providing that stiffness, because our models really don't have that. I mean, our muscles do have passive, stretch properties to them, but I think there's something that we're missing there.
Gotcha. Thanks.
Any more quick questions? There might be time for one more. I think Rick he's lucky enough to have one more meeting after this at 5:15.
I had a quick question actually about the dual task research you've been working on. Do you expect, I don't know if you're going to run this study like with older adults, do you think that they would show kind of similar, reactions with the dual tasks? Or do you think maybe, older adults are already focused more on their balance than younger adults, so they would kind of prioritize different things?
Yeah, my expectation is, so the next step is, so this was our a baseline study to be able to compare with individuals post-stroke, and of course we'll have some age-matched controls. And my guess is, well, it's actually going to be really interesting with the stroke subjects because they do have cognitive impairments and they also have balance control impairments, and so it'll be interesting to see what their priority is. My hunch is that they would prioritize their balance control. And so these were, in our study, young, healthy college students. And so they may not have much regard for their balance control in their bodies if they fall. It's like, but they do want to be able to spell those words correctly backwards. So it'll be interesting to see. But what I'm intrigued by, having both, the locomotor and also the cognitive impairments and how that interplays. So
yeah, awesome, thanks.
Yep.
Well, thank you, Rick. To give you 3 minutes to take a deep breath and get ready for your next meeting. Maybe we can give him a big round of virtual applause. And it was really nice to get to have you with us today.
Yeah, great. Thank you. This has been absolutely wonderful. Thanks. Appreciate it.
Rick, if you need more time, I can give you a few more minutes.
Oh, no, it's okay. I'm
Okay.
fine. Yep.
I'll see you in 2 then.
Okay, great.
Hi, everybody. Thanks for coming.
Okay.
Thanks again, Rick.
Thank you all. Appreciate it.
All right, looks like Ellen might be going to her other meeting. Do you still have that link?
I only had 2 links, I think.
Yeah, so just the regular meeting, like the one
Oh.
that everybody's going to. So I think she just popped out from the seminar link.
Gotcha.
I'll go ahead and stop the recording.
Okay.